All right. Morning, everyone. I'm going to be speaking today about cerebral vascular malformations. You've probably heard to some degree about these lesions before, but I'll just go through it in a little bit more detail. There are several classifications for vascular malformations. The original classification was by a pathologist named McCormick, and he characterized 5 different groups of cerebral vascular malformations, including telangiectasia, which is a small cluster of capillaries separated by normal brain. This is really not pathologic in any way, but it does represent one of the kind of vascular anomalies we can see in the brain. Varix, which is now known by its more common name of developmental venous anomaly. Again, not pathologic. It is a single dilated vein which can be found in the brain. It's normally associated with cavernous malformations, which is pathologic. Cavernous malformations are a low flow lesion composed of thin-walled vascular channels. And these can bleed. We'll talk about cavernous malformations in a little bit more detail in this talk. Arteriovenous malformations in another category. These are very high flow lesions. This is a complex tangle of arteries with no intervening capillary bed. So there's direct shunting of high pressure arterial blood into the veins. These can cause very severe brain bleeding. We'll get in detail of that. And then there's venous malformation. These are less common, and these are really clusters of veins separated by normal brain. And I'll show you an example of a venous malformation. So McCormick was the original classification of these cerebral vascular lesions. Modern classifications have a number of ways in which they can be classified. One way is to distinguish between lesions with arteriovenous shunting and those without. The ones without shunting include the telangiectasia, the developmental venous anomaly, cavernous malformations, and the venous malformations. Among this group, the ones that bleed are the cavernous malformations, and to a much lesser degree, venous malformations, very uncommon. The lesions with arteriovenous shunting, really it's just the AVM, and there's a true AVM, as well as the AV fistulas and vein of Galen malformation. So for this talk, we'll just go into detail about the clinically significant ones, which are the cavernous malformations, also known as Cavernoma, arteriovenous malformations, and the venous malformation. Treatment modalities we're going to talk about include surgery, and gamma knife, laser ablation, embolization. Back to McCormick's classification, he initially spoke about cryptic vascular malformations, and these are essentially cavernous malformations. And the reason they're characterized as cryptic is because you can't see them on an angiogram. In fact, back then in the 60s, when McCormick described these, you really didn't know what you were dealing with until you did gross pathology. Either a surgical specimen or a post-mortem. They didn't have CAT scans or MRIs to diagnose these things. But now we can see these things up front. We can know what we're dealing with. Cavernous malformations are low pressure, low flow lesions with small caliber arteries. No arteriovenous shunting is present, and they are found in 0.5% of the population. On MRI, they have a very distinct characteristic. They've been called a mulberry appearance. You can see one here in the medial temporal lobe, really in the uncus. It has mixed signal intensity. It's very common to have a hypo-intense capsule. This dark capsule is very common. When these things bleed, they often bleed intracapsular, meaning within this dark hemosiderin-laden rim, which is quite gliotic. The appearance on the MRI is also called a salt and pepper reticular appearance. So when we see these, we can readily identify them as opposed to something like a tumor, which is contrast enhancing often and doesn't have the characteristic kind of hemosiderin-laden capsule that these cavernomas have. We can also classify these anatomically by location in the brain, supratentorial, meaning in the forebrain. They can be superficial or deep. In the posterior fossa in the hindbrain, so these can be in the brainstem or cerebellum. Again, they can be superficial or deep. And we even find cavernous malformations in the spinal cord, ventral, lateral, and posterior. And really the anatomic classification helps us to have some theoretical understanding of the risks of treating them surgically. Obviously, the ones that are in the forebrain are supratentorial and are superficial are generally easily accessible and have the least morbidity of treatment. The cavernomas in the spinal cord and in the brainstem are often the most morbid to treat because of the eloquence of the surrounding neural tissue. Natural history, again, location is very important. If the cavernoma is located in relatively silent parts of the nervous system, then removing them have a much lower morbidity. The overall event rate for a cavernoma is actually on the lower side, on average about 4% per year. And event rate really characterizes both symptomatic and asymptomatic hemorrhages. People can harbor these lesions and not know they have them. But for symptomatic bleeding from a cavernoma, it's really only about 0.5% per year, which is quite low. Brainstem hemorrhage rate is reported as a little bit higher, about 3% per year. And it's not clear if really there's something inherently different about cavernomas or cavernous malformations in the brainstem. It may just be that the brainstem is so delicate and eloquent, and any loss of function in the brainstem will be noticed. So the rate of symptomatic hemorrhage is going to be higher in the brainstem as opposed to, let's say, the right frontal lobe, which is relatively quiescent. They do have a risk of seizure onset as well. It's one of the clinical characteristics of cavernous malformation bleed. Another thing that we often see with cavernous malformation bleeds is that when you have one, you're more prone to having another bleed. And that trend is apparent within the first 2 years. So the highest risk of a repeat bleed is within the first 2 years. Then, as you can see from the graph, after years 3, 4, 5, 6, really the bleed risk kind of comes down to the rate it was before the initial bleed. In the past, we've mistakenly attributed this phenomena of risk reduction after 2 years to certain treatments such as radiosurgery, but through analysis, we've figured out that really radiosurgery is not effective on these lesions, and it's really just the natural history of cavernous malformations to have a lower bleed rate after about 2 years. So what are the indications for treating cavernous malformations? Well, we often find them incidentally, as I mentioned. People get brain MRIs and CAT scans for all kinds of reasons, and we sometimes see them. We know that the rupture rate is relatively low, and the morbidity from cavernomas that rupture is actually much less than that from an AVM or aneurysm rupture. So we are really quite selective about treating cavernous malformations given these kind of natural history characteristics of, one, having a relatively low rupture rate, and two, when they do rupture, they tend to not result in severe morbidity in the way that the high flow arteriovenous shunting lesions can, and in the way that aneurysms can. So we look at the location, whether it's eloquent, can we easily access the lesion? We also look at the history of the patient, their family history, and their history of whether they were symptomatic or not. About 20% of cavernous malformations that are multiple are sporadic. About 50% of them are familial. Interesting thing, in the familial variety, we often see multiple. You can see in this brain, it has really innumerable cavernous malformations. And this is a patient who obviously has a non-surgical pathology, given the vast number of cavernomas that are present. There are genes that have been identified as causing a predilection towards harboring cavernous malformations. These are the names of the genes: CCM1, CCM2, and CCM3. So, a lot of work has been done there at a basic science level, telling us who may be at risk for both having and passing these on genetically. Most common indication for removing a cavernous malformation really is it symptomatic and is it accessible? Again, for example, in this case here, you can see the cavernous malformation at the surface, and it's readily accessible, and certainly if it's symptomatic, we wouldn't hesitate to go ahead and remove it. In a real example here, you can see this this cavernous malformation at really the surface in the anterior left frontal lobe. It's causing intractable seizures. It was easily removed, and in fact, doing that cured the patient of their seizure disorder. So that's certainly one of the indications for that. Now, there are special techniques for removing tumors from eloquent brain regions. There's functional imaging, which can be done. In fact, that patient with this left frontal cavernoma, we did a functional MRI looking for the speech areas. And you can see the arrows pointing to the area that activated with speech. So we avoided that area with functional mapping during surgery and removed the cavernoma. And that was an excellent way to remove this, this lesion from potentially eloquent region of brain. There are techniques that we can utilize, such as laser ablation for cavernous malformation. This is really an emerging technique. There have been several papers put out about this recently. We use stereotactic targeting of a laser electrode to the center of the lesion, and rather than removing it, this is a rather deep malformation, we'd have to go through quite a bit of brain to get to it and remove it. Well, with the laser technique, you leave the cavernoma in place, you put the electrode into the center of the lesion, and you essentially burn it. And we believe that this may have the potential for reducing the hemorrhage rate, but I have to say that more research has to be done on this to really elucidate whether it's a viable technique or not. But it does seem promising from early results. We spoke about the capsule of cavernomas, but we can see that some hemorrhages from cavernous malformations will break free of that gliotic capsule and can really result in significant mass effect. In this case here, there was quite a large right posterior temporal lobe hemorrhage from this cavernoma. And given really the mass effect and the increased intracranial pressure, this was a case that was good for resection. And you can see the postoperative result here. Other indications for resection of cavernomas include location, where it has a higher propensity to bleed. This cavernoma here, you can see by the arrow, is really located in the subependymal region of the brain. So there really is no tamponading brain around aspects of this cavernoma that would prevent any sort of bleeding into the ventricle. And so we consider this a high-risk lesion for causing a massive intraventricular hemorrhage, hydrocephalus, and we all know that that can result in sudden death. So we are more likely to treat a lesion such as this. Brainstem cavernomas, vast majority of neurosurgeons are initially conservative with these. Again, the brainstem is quite a delicate area, and we try to avoid operating in the brainstem unless it becomes absolutely necessary. If there are multiple intracapsular hemorrhages, those are often well tolerated. However, if there's a hemorrhage that protrudes out of the capsule and comes to an ependymal surface, we're more, or the brainstem surface, we're more likely to try to remove it. We don't like to go through actual brainstem tissue, such as in this direction. But if the cavernoma really comes to the edge of the ependymal surface here, that gives us a nice avenue for resecting it. And one case is here. You can see that the cavernoma or cavernous malformation is exophytic to the medulla. It actually kind of protrudes out the back, and that this is a case that hemorrhaged 3 or 4 times, and we finally decided that it was time to remove it. So how we did this was we did a suboccipital craniectomy. We essentially lifted the cerebellum to expose the posterior part of the medulla, and you could really see it from the surface. And we didn't have to transgress through normal medulla to get to this. So this was a nice case for surgery. Other indications for resection of these cavernous malformations: intractable headaches. Most of these lesions are incidental, but headaches are a common reason for getting brain imaging. So, if we see a large cavernoma that may be causing headaches, we certainly try conservative management first, but certainly if they're in a reasonable, safe area to remove, we offer that treatment to patients. Lesion expansion, we can see both symptomatically and asymptomatically. Certainly if it's symptomatic in any way, And in an area that can be resected, we will offer that. I mentioned developmental venous anomaly as a lesion that can be associated with cavernomas. The DVA, or developmental venous anomaly, is actually essentially draining normal brain, and they're often adjacent to these cavernomas. When we remove the cavernoma surgically, we leave the adjacent developmental venous anomaly because it's really just draining normal vein. It's draining normal brain tissue. Removing them can actually be quite dangerous, causing a venous infarct. So that's important to know. Histologically, these DVAs have been described as having a caput medusae appearance. This is how it looks on an MRI, and this is kind of gross tissue appearance here. So let's move on to arteriovenous malformations. These, unlike cavernomas, are very high flow, high risk lesions. It's an abnormal network of arteries and veins where there is arteriovenous shunting of blood without an intervening capillary network. So you're really having the high pressure within the arterial system being transmitted to the venous side, and that creates a potential for a significant amount of bleeding. Most AVMs will become symptomatic. It's just a fact. Up to a 25% death rate has been reported, and 50% neurological disability with arteriovenous malformation hemorrhage. There is a grading scale that is commonly used called the Spetzler-Martin grading scale. It really was developed as a way to gauge the morbidity from surgically removing these lesions. The grading scale is based on the size of the AVM. Larger ones get a higher score. The location, whether they're in non-eloquent versus eloquent brain. Those in eloquent brain get a higher score, and it also describes the venous drainage, whether it's superficial or deep. Deep venous drainage gets a higher score. The highest grade you can get is a grade 5, that being a large AVM greater than 6 centimeters, located in eloquent brain and having deep venous drainage. So that would be a grade 5 lesion. And the original paper, grade 5 lesions had a pretty high rate of deficit. The most common presentation of arteriovenous malformations is hemorrhage. Okay, hemorrhage risk is about 4% per year, about 7% per year morbidity, and 1% per year risk of mortality. This is from Ondra et al., one of the most commonly cited papers regarding the natural history of AVMs. But you can see from the figure here, this is a left side frontoparietal hemorrhage. From the MRI, you can see that there are flow voids in the area of the bleed. Then a catheter cerebral angiogram was done, which demonstrates pretty clearly the arteriovenous shunting. This is the arterial side here. This is an internal carotid artery injection. These are dilated arteries leading to a nidus, which is the tangle of arteries where the shunting occurs. And then you see the large draining vein. The arrow is pointing to the draining vein. And you really see all of these things show up on a early arterial phase injection on this angiogram. And these are really the characteristic features of an arteriovenous malformation on angiogram. Risk factors for bleeding. a prior hemorrhage. If you had a prior hemorrhage from an AVM, you're more likely to have another one. So that's similar to the cavernous malformation tendency to bleed within the first 2 years. For some reason, AVMs show a very similar characteristic. If you have deep venous drainage, you're more likely to bleed. And the nidus location, if you're deep in location, you're more likely to bleed. A rebleed rate within the first year, it can be up to 18 to 20%, so relatively high. We often put AVM patients who have bled in a very different category from patients with asymptomatic AVMs that have not bled. We often treat these patients who have bled much more aggressively than the incidentally found AVMs. There was actually a relatively recent study called ARUBA, a very controversial study, which came up with the conclusion that medical management is superior to interventional management of unruptured brain arteriovenous malformations. I hesitate to even mention this study because there's so much controversy surrounding it. But I mention it really just to indicate that there's a lot of controversy surrounding how to manage people with unruptured and asymptomatic AVMs, okay? So what are some ways that we treat AVMs? Well, we can embolize them. And the goals of AVM embolization are manifold. One, to eliminate deep arterial feeders. And that's very helpful if we're actually planning to go ahead and do surgery on them. When you eliminate deep arterial feeders with embolization, that can make your surgery much safer, as it gets rid of arteries that are hard to see, at least in the initial part of your surgery, and it slows down the blood flow within the nidus, which is certainly very helpful for microsurgical resection. Embolization can also compartmentalize very high-grade lesions, make them more amenable to radiosurgery or microsurgery. You can do targeted embolization to treat the high-risk features of the AVM. You can get rid of areas where there's vascular steal to normal brain. You can treat the venous hypertension. You can, in some cases, even eliminate seizures with well-targeted embolization. These targeted embolizations aren't necessarily curative of the AVM, but they are really focused on helping a specific neurological issue that may be arising from the AVM. There may be a way to reduce the hemorrhage rate during the latency period after radiosurgery. We'll talk a little bit about radiosurgery and what that means. We spoke about targeted embolization, and flow reduction is also a big reason why we do AVM embolization. So in terms of microsurgery, you can certainly get immediate elimination of or reduction in the hemorrhage risk by removing the AVM. As you can see in the picture here, this was an occipital arteriovenous malformation that was surgically removed. This is a gross specimen here. The nidus, you can see the tangle of vessels. Really, once you've removed the arteriovenous shunting and confirmed that on angiogram, there really should be no source of hemorrhage left. So that's one of the excellent things you can get from actually removing the AVM with microsurgery. You can treat the AVM-related symptoms such as steal. You can treat AVM-related epilepsy by removing not only the nidus, but you may have epileptogenic brain surrounding it, gliotic brain surrounding the nidus, which can also be resected. And removing AVMs microsurgically also treats headaches, which is often an overlooked advantage of removing AVMs. There are a number of papers out there regarding AVM-related headaches. They're often unilateral on the side where the AVM is located. These types of headaches are often associated with AVMs in the occipital and parietal occipital regions. For some reason, these seem more likely to result in headaches. Radiosurgery is another technique that we use to treat AVMs, and specifically the gamma knife has shown very good results, 80% or better cure rates in select patients. With the gamma knife, with radiosurgery, you get gradual occlusion of the AVM as this high intensity beam of radiation results in intimal hyperplasia of the blood vessels and eventual thrombosis. The whole process can take about 2 to 3 years though. And we often remind patients that during that 2 to 3 year latency period, they still are not protected from hemorrhage. So we do have to confirm after that 2 to 3 year waiting period that they responded appropriately to the gamma knife radiation. However, it is a minimally invasive strategy and can avoid some of the upfront risks and complications that you can see with embolization and microsurgery. There are grading scales out there to tell you who might be a good candidate for gamma knife. Not everyone is. In this case, this was a deep arteriovenous malformation in the basal ganglia. This one had not hemorrhaged, but given its high Spetzler-Martin grade score, it was a grade 4, 30% operative morbidity based on essentially it's a radiosurgery grading scale, the Pollack-Flickinger grading scale. We calculated about a 65% excellent outcome with radiosurgery. And this patient had a lifetime risk of hemorrhage without treatment of 60%. Based on this sort of analysis, we went forward with treating this patient with radiosurgery. And really, this patient had quite an excellent outcome. I wanted to talk a little bit about staged embolization, which is a technique for dealing with very large arteriovenous malformations. It allows you to gradually acclimate the brain's normal blood flow to changes in the hemodynamics when you embolize it. We like to do this for the large lesions. In my opinion, gradual embolization reduces the rupture rate of these lesions. You can see this is a very large right frontal AVM. This is the internal carotid artery injection on catheter angiogram. And really after several embolizations with glue, this AVM was really taken down to almost nothing. It really made surgery quite easy. And so the endovascular surgeon is certainly your friend when you're planning a neurosurgical resection of these large lesions. This is a picture of deep feeder embolization. This is a sort of a right side insular region AVM. You can see it here on that catheter cerebral angiogram. This is the nidus fed by the middle cerebral artery. But the artery of interest here is this small one here. And this is a lenticulostriate feeder, which is on the deep side of the AVM. And this is a microcatheter angiogram of that singular deep feeder, which really would be the last vessel you would encounter when microsurgically resecting this. And so we asked our endovascular neurosurgeon partner to embolize this deep feeder, which helped tremendously with the surgery. And so, you know, when we came in surgically on this lateral side, you can't see the back end, but we can deal with everything on the surface very readily. And certainly that deep feeder embolization was quite helpful to removal of this AVM. Embolizing flow-related aneurysms. Aneurysms that are associated with AVMs are very high risk. We often go ahead and treat the aneurysms that we see on associated vessels while leaving the AVM alone, because we know that the associated aneurysms are such high risk. And embolization is certainly helpful in that regard. And so we can treat the aneurysm up front and sort of in an elective fashion go ahead and deal with the large AVM-nitis. In some cases, you can actually cure an AVM with embolization. It's probably only about 15 to 20% of AVMs where that can be done. The most common ones are the ones with only a single arterial feeder, such as this one. And you can see there, really after you have embolized the nidus, there's no further AV shunting. And so that represents a cure. The vast majority of cases, we're doing multimodality treatments where a portion of the AVM is first embolized and then it is resected microsurgically. We can see hemorrhage after AVM embolization. And really, this is why we work as a team. Whenever Dr. Ortiz or Dr. Cerulli are embolizing an AVM, I'm always around in case there's an issue. In this case, patient had a hemorrhage in the angio suite, and we took the patient expediently to the operating room and did a decompression and resected the AVM with good outcome. Normal perfusion pressure breakthrough is a phenomenon that was described as the etiology of some of these post-procedure hemorrhages, and it's thought to be due to a loss of autoregulation in the arteries and arterioles surrounding the brain. And essentially, when you've reduced flow into the nidus of the AVM, it can divert high pressure blood into some of the surrounding arteries that have lost their ability to autoregulate. And when that happens, that can really result in disaster where these vessels tend to rupture. The idea of staging embolization is one of the ways that we try to mitigate this issue. Other etiologies of post-procedure AVM hemorrhage: occlusive hyperemia. You can see this from obstruction of venous outflow, where you have high pressure blood coming in from the arterial side, but nowhere to go on the venous side, causes stagnation and hyperemia in the brain and eventual bleeding. Other causes: residual AVM. If it happens after surgery, it could be trauma to the surrounding surgical bed, inadequate hemostasis, coagulopathy, or hemorrhagic conversion of an ischemic stroke. So I mentioned some of these things already. So let's talk about some of the other malformations. Dural Arteriovenous Fistula. These are another type of high flow vascular brain lesion with AV shunting. And these are interesting lesions. They can be characterizing to the low-risk lesion and the high-risk lesions. The low-risk ones are where you see direct arteriovenous shunting from an artery into a venous sinus, but the flow is in essentially the normal direction. So in this case, this artery flows into the transverse sinus, and then blood essentially flows down the jugular vein in the normal direction and goes back to the heart. In the high-risk fistulas, you see shunting into the sinus, but then there's cortical venous reflux. So there is really the brain parenchyma is seeing high pressure blood as being refluxed really in the wrong direction of blood flow. And these are pretty high risk for bleeding. And so we can assess whether we need to treat an arteriovenous fistula based on this characteristic. Some of these low-risk lesions can still cause symptoms, things like pulsatile tinnitus and headache, and that may lead us to treat some of these low-risk lesions. Anyway, they're low risk for bleeding, but certainly can cause a quality of life issue, and so we sometimes treat these. These high-risk ones, whether they are symptomatic or not at the time of presentation, we tend to treat to really reduce that high risk of brain bleeding and morbidity that can come from that. Carotid cavernous fistula is a special type of dural arteriovenous fistula. There's AV shunting from the carotid artery system into the cavernous sinus. And there are really 4 types of CC or carotid cavernous fistula. There's a direct fistula from the internal carotid artery into the sinus. You can have it directly from the main branch of the carotid artery itself, or from a small arterial branch from the carotid. You can have a fistula from the external carotid system into the cavernous sinus, and these 2 types are illustrated here. Vein of Galen malformations are an interesting one. These you often see in little babies, and they're often symptomatic with high output cardiac failure, because so much of their cardiac output is being shunted into this dilated pocket called it's a dilated vein of Galen. There are 2 types, choroidal type, the mural type. These are often treated at least partially in the neonatal period to palliate the high output cardiac failure. Then definitive treatment often happens later on in childhood. This is an example of a vein of Galen malformation in an adult that was treated. This patient actually presented essentially with dementia from all the venous hypertension that was created by the vein of Galen arteriovenous shunting. And this was treated transvenously. You can see all these coils were put into the dilated pocket of the vein of Galen, and that significantly reduced the shunting, and his dementia actually improved. This is an example of a venous malformation, really the last category that McCormick spoke about in his classification. And these are very rare. This venous malformation called Sinus Pericranii, which you can see here on this MRI, is essentially a venous malformation where an extracranial vein is connected to an intracranial venous sinus. In this child, it was diagnosed by the mother noticing pulsing of the scalp. And often these are treated, often they're not treated, they're just observed. But in this case, there was thought to be a high risk of bleeding because the vein was relatively superficial. And so the child actually underwent surgery to disconnect the superficial scalp vein from its connection to the sinus. Well, I think that's really the summary I wanted to give of some of the vascular lesions in the brain, and I think we have some time. We can take some.
Yep, I just opened the chat for questions now. Someone said, with the grading scales of AVMs, is there any way that tests can be close in results? If so, how do you decide which surgical route to take?
I'm sorry, say that again. Is there any way that what?
With the grading scales of AVMs, is there any way that the test can be close in results? If so, how do you decide which surgical route to take?
So the ways that we treat AVMs include surgery, embolization, radiosurgery, and sometimes we don't treat them. So I would say it's a very complicated algorithm deciding, one, whether we're going to treat an AVM or not, and two, the type of modality that we're going to use. In general, if an AVM has ruptured, we are in all likelihood going to go ahead and treat it. Okay, now the question becomes, which modality do you use? In a ruptured AVM, we're less likely to use, we're less likely to observe, and we're less likely to use radiosurgery, because radiosurgery takes about 2 to 3 years to actually occlude the AVM. So I would say in the majority of symptomatic ruptured AVMs, we're doing a combination of embolization and microsurgery. And whether it's can be embolized depends on the angioarchitecture once an angiogram is done, and whether it can be resected depends on the actual location, how deep it is, what sort of normal brain do you have to transgress to get to it. So essentially, it's a very complicated situation, and we usually have lots of conferences and discussions about it. So there really is no singular answer to that.
Someone asked, is it ever possible to detect and implement developmental interventions if a malformation occurs during pregnancy?
Yeah, we've definitely found AVMs during pregnancy. And in fact, we've operated on both pregnant women with ruptured AVMs, and in some cases, if they're far along in their pregnancy, we go ahead and ask the OB team to deliver the baby, and then we immediately go ahead and remove the AVM if it is symptomatic and life-threatening. So yeah, we can do angiograms in pregnant women. We don't like to. There are ways to protect the growing fetus. We can do microsurgery in pregnant women. We don't like to, but we can monitor during general anesthesia, and if it needs to be done to save mother and baby, we certainly do it, and we have definitely done it.
Great. Someone asked, why are venous malformations less common?
That's a question for God. That's just how we're made.
Someone said, could you further explain the relation dementia had to the malformation?
Yeah, so in that patient I showed was an adult patient with a symptomatic vein of Galen malformation. And that patient had uh, uh, something called elevated intracranial pressures. And the reason he had elevated intracranial pressures is because he had venous hypertension. You can imagine that if high flow arterial blood is getting to the venous side, which is generally a low pressure drainage side, um, that would really reduce outflow from the brain, and that increases pressure in the brain. And in his case, it caused dementia. So once we were able to reduce flow of blood from the arterial side to the venous side, that reduced his intracranial pressure and allowed his dementia to resolve.
I think we'll take one more question now. What are some risk factors for developing AVMs? Is it related to a mutation of a gene?
AVMs are thought to be congenital lesions, so you're born with them. Unlike, let's say, an aneurysm, which are not thought to be congenital. Aneurysms, there are definite risk factors such as smoking, such as we believe hypertension may be a risk factor for rupture. Certainly being a woman with is a risk factor for both developing aneurysms and for them rupturing. AVMs, not so clear-cut what the risk factors are that are modifiable. We know that cavernous malformations, there are definite genes, and I mentioned some of them, but AVMs, we don't have as clear-cut genetic history, although we know that they are congenital.
Thank you so much for speaking again for us, Dr. Ellis.
All right, you're welcome. I'll see you again for another lecture, I guess, in a couple weeks.
Yep, thank you.
All right, bye.